Welcome to the debate. When you walk into an urgent care center or an emergency department, you're usually thinking about the immediate physical problem, a broken wrist, a high fever, maybe a deep cut that needs stitches. It's a place of rapid turnaround. Treat the issue, clear the bed. But there's a profound transformation happening in these spaces right now that is, well, invisible to most people. These acute settings have effectively been drafted as the front line of the suicide prevention crisis.
It's a massive shift in mandate. We're taking facilities designed for speed and physical triage and asking the clinicians inside, who are often working on strict 15-minute timers, to become the gatekeepers of life and death for complex psychological crises.
And that brings us to the central tension we're wrestling with today. The question is this: should the medical system adopt a sort of totalizing zero suicide framework? One that utilizes universal screening and aggressive intervention to try and prevent every single death? Or does that approach risk over-medicalizing human distress, infringing on civil liberties, and creating a liability-driven dragnet that might actually create more trauma than safety?
It's the tension between safety and liberty in its rawest form. On one side, you have the imperative to save lives at any cost. On the other, the risk of stripping autonomy from patients and trapping them in a system that doesn't actually have the resources to help them.
To state my position clearly, I represent the view that suicide deaths under healthcare supervision are fundamentally preventable system failures. I believe in the zero suicide framework. That means universal screening, rigorous standardized protocols, and yes, the moral imperative to intervene, including involuntary commitment, when the data suggests a life is at risk.
And I come at it from a different angle. I'll be arguing for a more nuanced approach that prioritizes civil liberties and really questions the efficacy of this kind of broad surveillance. I worry that liability fears are driving clinicians to use coercive measures, like involuntary holds, far too freely, potentially stripping patients of autonomy and clogging the system without addressing the root causes.
Okay, so let's start with the scale of the problem, because I think the zero suicide framework is often misunderstood as just a slogan. It's actually a fundamental shift in how we view patient safety. The foundational belief is that we have to move away from a fragmented approach toward a high-reliability system, and the reason for that is the data regarding who is walking through those doors.
You're referring to the prevalence rates in non-psychiatric settings?
Exactly. Current clinical data suggests that approximately 8 to 10% of adult patients presenting to acute unscheduled care settings harbor recent suicidal ideation or behaviors. And here's the critical part. That's true regardless of their primary medical complaint. They might be there for a migraine or back pain or a flu test. But underneath that, they're carrying this invisible risk.
I don't dispute the prevalence numbers. What I dispute is the assumption that the medical system's current infrastructure is the right tool to address it. You call it invisible risk, but when we try to make it visible through universal screening, we're creating a dragnet. My thesis is that while preventing suicide is noble, the mechanisms we use, specifically involuntary commitment and universal screening, represent a massive curtailment of liberty.
But if the risk is invisible, how can we possibly offer help? If we don't ask, we don't know.
The question is whether the help is actually helpful or just coercive. The Supreme Court in Humphrey v. Caddy explicitly stated that involuntary commitment is a, quote, massive curtailment of liberty that requires due process. When we shift from predicting suicide to planning for safety, we often end up relying on tools that lack validity. Physicians, they often use dangerousness assessments as post hoc justifications to avoid liability. They're terrified of being sued, so they err on the side of locking people up. That's not a therapeutic alliance, that's defensive medicine.
I'm just not convinced by that line of reasoning because the stakes of missing the sign are absolute. Consider the post-discharge window. Research shows that the risk of death is highest within 30 days of discharge. Furthermore, 70% of patients discharged after a suicide attempt never begin outpatient treatment. If we don't catch them in that urgent care visit, if we don't intervene then and there, we are dropping them into a void.
Or we're trapping them in a revolving door. Locking people up temporarily without long-term resources does not solve the underlying issue. It just kicks the can down the road while stripping them of their rights in the interim.
Let's talk about the mechanics of how we find these patients. This brings us to the concept of universal screening,
Which I view as a logistical and, frankly, ethical minefield in an urgent care setting.
I disagree. The evidence supports universal screening using validated tools like the ASQ, the Ask Suicide Screening Questions, or the PSS-3. There's this persistent myth that asking about suicide plants the idea in a patient's head. The evidence shows the exact opposite. It often provides relief. Patients finally feel they have permission to speak about their pain.
I'm sorry, but I just don't buy that it's that simple. Sure, the ASQ only takes 20 seconds, but in an urgent care setting, a positive screen is not just a data point, it's a legal detonator.
A detonator? It identifies 97% of at-risk youth. That's a success, not a detonator.
It triggers EMTLA, the Emergency Medical Treatment and Labor Act. Under EMTLA, suicidal ideation is considered an emergency medical condition. Once a patient screens positive, you can't just let them go. You have to stabilize them. In a high-speed urgent care, that's an operational nightmare.
You're arguing that relying on clinical intuition fails because patients mask distress. I'm arguing that universal screening traps clinics into holding patients they cannot treat.
That is why the protocol matters. You can't use homegrown screening tools. The Joint Commission's Heads-Up report explicitly warns against using made-up questionnaires because they lack reliability. If you use the ASQ or the CSSRS, you have a validated pathway. You aren't guessing. But look at the physical environment. If I screen everyone and I find a high-risk patient, where do I put them? Most urgent cares do not have a safe room. We're talking about a room that is ligature-resistant, with tamper-proof screws, flush-mounted TVs, doors that swing outward so patients can't barricade themselves in. If a clinic lacks that infrastructure, screening everyone creates a legal trap. You identify a risk you cannot safely manage, and now you've created liability for yourself because you have a suicidal patient in a room full of medical sharps and cables.
That is an argument for better infrastructure, not for ignoring the risk. The solution is not to stop looking, it's to make the environment safer. The Joint Commission requires environmental risk assessments. You remove the anchor points, you remove the hooks, you institute one-to-one visual surveillance. That is Code 1 or Code 2 on the Australasian triage scale. You don't just throw your hands up because you lack a flush-mounted TV. You adapt.
That adaptation often looks like a security guard staring at a patient for 12 hours while they wait for a bed that doesn't exist. That isn't treatment, that's detention. And frankly, paying a staff member to sit one-to-one with a patient cripples the rest of the clinic's ability to function.
It is stabilization, and once we've identified them, we move to intervention. This is where the zero suicide framework really shines, specifically in the shift toward collaborative safety planning.
Safety planning sounds nice, but in practice, it often just devolves into the contract for safety.
I want to be very clear. The contract for safety is outdated and dangerous. It's a liability shield for the clinician, nothing more. Sign this paper promising not to kill yourself so I don't get sued. We are moving away from that. I am advocating for the Stanley Brown safety plan.
That's a compelling argument, but have you considered the time constraints? A Stanley Brown plan requires identifying warning signs, internal coping strategies, social distractions, support networks. In a 15-minute urgent care visit for a sinus infection, are you really building a robust safety plan?
We have to make time. It's a prioritized list. It empowers the patient. And crucially, it involves lethal means counseling, or CALM. This isn't just bureaucracy. It involves actively securing firearms and medications. If a patient has a plan involving a gun and we send them home without addressing that access, we have failed.
I agree that means restriction is effective in theory, but lethal means counseling can feel incredibly intrusive to patients, particularly regarding firearms. You're asking a doctor who has known this patient for 10 minutes to negotiate the surrender of their weapons. That requires a level of rapport that urgent care doctors rarely have time to build. It can shut the patient down completely.
It is a necessary conversation. We discuss sexual history, drug use, other sensitive topics. Firearms should be no different when life is at risk.
And what about the intoxicated patient? This is a massive issue in urgent care. A patient comes in drunk, expresses intent to die. The protocols, zero suicide included, demand we hold them until they are sober to assess cognitive capacity.
Because you can't assess risk in an impaired patient. They might deny it when sober, but that doesn't mean the risk is gone. Alcohol is a massive disinhibitor.
But keeping them until they're sober turns urgent cares into drunk tanks. They express intent while impaired, deny it when they sober up, and in the meantime, they're taking up a bed and resources. It creates a boy who cried wolf dynamic that burns out staff and arguably does little to treat the underlying issue.
We cannot dismiss the threat just because the patient is intoxicated. That is a gamble with a human life. And this leads us to the hardest call of all, involuntary commitment.
This is where the rubber meets the road regarding civil liberties.
It's about the duty to protect. I want to cite Chance v. Bon Secours Hospital. In that case, a patient was released early and died by suicide. The court found the physician liable for premature discharge. If a patient meets the criteria, danger to self, the state's parents patrie power obligates the physician to act as a protector. You can't just discharge an unstable patient.
I see why you think that, but let me give you a different perspective using Williams v. Peninsula Regional Medical Center. In that case, the Maryland court protected a physician's discretion not to admit. The court recognized that if we punish doctors for not committing people, we encourage defensive medicine, where everyone gets locked up just in case.
But in Chance, the patient was already in the system. The failure was the premature release. We are talking about the overt act standard. Some argue you need an overt act of violence or self-harm to justify commitment. I argue that ideation with a plan is enough danger to warrant intervention.
I disagree. I argue for a stricter dangerousness standard. Without an overt act, we are policing thoughts, and the liability fear is real. Look at Barker versus Netcare Corp. A facility was liable for $150,000 for false imprisonment because they restrained a patient without following the formal commitment proceedings.
That was a procedural failure. They didn't follow the law.
It was a failure of a system that traps clinicians. They're damned if they do, damned if they don't. And let's talk about the transport aspect of commitment. In states like Tennessee, do you know who transports mental health patients to psychiatric facilities?
That's a resource issue, not a clinical one.
It is a trauma issue. We are taking a person in crisis, putting them in handcuffs, and putting them in the back of a police car. We are criminalizing a health crisis. That experience alone can be more damaging than the initial ideation. If your zero suicide framework relies on sheriffs and handcuffs to move patients to safety, is it really safety?
It is imperfect, I grant you. But the alternative, letting them walk out the door to die, is unacceptable. The Chance case shows us that liability exists when we fail to protect. The Australasian triage scale is clear. If they are code 1, they are in an immediate danger. We have to strip liberty temporarily to ensure there's a life to live later.
But we often strip that liberty and then dump them right back into the void. This brings us to the gap, the transition of care.
This is where the system fails most often, I agree. We need warm handoffs.
A nice phrase. What does it mean on the ground?
It means scheduling the follow-up appointment before the patient leaves the building. Ideally within 24 to 72 hours. We know that the risk of suicide attempts and death is highest within the first 30 days post-discharge. If we just hand them a piece of paper with a phone number, we have lost them.
But you're ignoring the workforce shortage. A warm handoff implies there's someone on the other side to catch the patient. With national shortages of psychiatrists, getting an appointment in 24 hours is often a fantasy.
If we can't get an appointment, we use caring contacts.
Sending a postcard?
It sounds trivial, but the data is robust. Sending postcards, text, or emails post-discharge reduces suicide attempts. It creates a sense of connectedness. It's a pathway to care. It is low cost and effective.
I'm sorry, but I just don't buy that a text message fixes the structural void. If outpatient care isn't available, the urgent care becomes a boarding facility. We are holding patients for days because there are no beds. A postcard doesn't solve that. It's a Band-Aid on a broken system where 70% of attempters never start treatment.
It's a lifeline, not a Band-Aid, and it keeps them engaged until the system can catch up. The Joint Commission requires these transition protocols for a reason.
And I would argue those requirements are aspirational at best and Well, delusional at worst, given the current staffing realities. Let's bring this to a close. My position remains that zero suicide is the only acceptable goal. We have the tools, the ASQ, the Stanley Brown Safety Plan, the caring contacts. The failure is not in the science, it's in the implementation and the culture. We must prioritize life over the discomfort of intervention. If we have to risk a lawsuit for false imprisonment to save a life, that is a risk a physician should take. But more importantly, if we follow the protocols, if we document the risk in the plan, we protect the patient and the provider.
That is a compelling argument. But I will worry it leads us down a path of authoritarian medicine. While saving lives is essential, we must be wary of a system that equates safety with control. A system driven by EMTOHL mandates and fear of lawsuits risks trapping patients in a revolving door of coercive holds. We handcuff them, transport them, hold them, and then release them into a world with no psychiatrists. We haven't solved the problem, we've just paused it and potentially traumatized the patient in the process.
It is a difficult balance. The physician is constantly weighing the duty to protect against the duty to respect rights.
Exactly. And while protocols are necessary, they cannot replace clinical empathy. The material suggests we have the framework for safety, but perhaps not the infrastructure to support it humanely.
That is a fair critique. There is much more to explore in the tension between these protocols and the reality on the ground.
Indeed. Thank you for listening.
Thank you for joining the debate. We encourage you to dig into the source material and decide for yourself where the line should be drawn.